Despite all these really, really outstanding, excellent results, we're not curing everybody with CAR T cells. There's patients who basically don't respond, and there are patients who actually unfortunately relapse despite having a response. Karen, do you want to lead through some of the reasons we're finding?
So, I mean, one big reason is T cell fitness, and I think we're all now starting to understand a little bit more about what are the types of T cells within the product that predict for efficacy, and then thinking about how to sequence therapies beforehand or how to influence the T cell phenotype of the product in order to enhance the types of T cells that lead to improved outcomes. The other one is obviously antigen loss, and so I think, again, I'm not a leukemia doctor, but I think it's actually as high as 50% antigen loss in the ALL population upon relapse. And we think CD19 is the reason it was picked as an important tumor target is that we think it's essential for the B cell and the malignant B cell to survive. So it's astounding, how does the B cell lose the antigen and stay alive? But it's not that they're actually losing the antigen; it's that the gene is being alternatively spliced, and so the epitope that the CAR is binding to, and also it's the epitope that many of our immunohistochemical stains and antibodies bind to for the purpose of flow, no longer can see CD19 on the surface of the malignant cell, and so that's an important mechanism of escape.
I think that's very.
So Max, how do we fix that?
Well, one way is maybe just to go after other antigens that are commonly expressed, like on CD22, and that we may come in with clinical trials where we use a bicistronic approach targeting both CD19 and CD22, so we're just applying more pressure to leukemia in that situation.
I mean, just like we'd never use just one antibiotic for a serious infection, we usually use two, and so I think it's the same kind of approach.
HIV is really the paradigm for this, right? With a rapidly mutating virus, that we see that if we target more than one pathway, the virus can't keep up, or you decrease the selective pressure for any of those mutations.
Frontline chemotherapy for aggressive malignancies is often combination chemotherapy. It's the same idea of having to pay a cost to escape one mechanism. You can't pay the same cost multiple times over.
I mean, it may be also interesting with our novel technologies in like NGS sequencing that we actually can also trace clones. And it's an clonal disease. It's not just one clone. It's like so if we have a better understanding of the clonal architecture, then we can predict patients that we at risk, then decipher, then that more interrogate the signature and to apply which kind of pressure we want to give the leukemia in that situation.
I think it's also important, though, to recognize that although we do see CD19 antigen or epitope loss of where the CAR binds, that this is probably not the only mechanism of treatment resistance. There's data in ALL patients treated with 4-1BB constructs that actually loss of persistence of the construct may correspond to relapsing disease, but we also have to be careful to say that that's in a specific CAR with a specific construct in a specific disease that may not hold the same for lymphoma and multiple myeloma. But we really don't fully understand the reasons that patients may not respond or have durable responses to CAR T cell therapy. So we really need to do additional translational discovery.
I mean, one field also is that there are also resistance mechanisms like upregulation of checkpoint pathways. And there's something else that we also may dip into, that we can give the checkpoint inhibitors to actually help the CAR T cells to actually fight off that resistance mechanisms. And that'd be, I think, a very interesting field of research, clinically very useful too, potentially down the road to actually get a higher cure rate.
We're beginning to see some of the data pop up with CD22 and CD19 CARs with either two CARs or bicistronic CARs. And I think that's going to maybe decrease some of this. But I want to come back to the T cell fitness. I mean, right now, the patients that are really being treated are relapsed refractory. They've been through multiple therapies. Obviously, your T cells can't be very healthy after all these treatments. So is there a role for collecting T cells from high-risk patients maybe early on in their disease before they go through all this therapy?
I think scientifically it absolutely makes sense. There's strong data to suggest that patients who've had more lines of chemotherapy or have less fit T cells at the time of collection for manufacture of CAR T cell therapy, their end CAR T cell product is not as strong or fit, and they're less likely to have responses or durable responses. I think it does introduce some complexity when we get beyond the scientific aspects of it, which is, can we be collecting cells and can we be holding them in freezers, and who's going to do that, and what are the payment mechanisms to do that?
I think excellent points.
And not all of the products are produced from frozen products also, right? So that also, this concept is limited to certain products that that are only produced from frozen cells.